the focus of yesterday's yesterday's discussion was on thyroid, and I wasn't able to come yesterday, so I just thought I'll speak to you today on what are the complications we would encounter during an advanced thyroid cancer. Now, there aren't really a lot of complications if you are planned well. And the previous session you heard of how if we have investigated adequately, you would have a very good planned surgery. Now, when you look at an advanced thyroid cancer, this is what you would see in a routine presentation: a very large swelling and an imaging that looks, quite ghastly and scary, because that's how thyroid imaging always looks. So don't go by the image. Look at symptoms. Look at how the patient's presenting, and then plan the treatment. These are usually difficult to treat cases, and they're fraught with a lot of recurrences and poor survival, which is in contrast to a routine thyroid, where the patient usually will outsurvive you because they're younger. So, in advanced thyroid cancers, where do they actually spread? They'll spread to the local structures such as the straps, the surrounding organs, such as the trachea, larynx, and esophagus, and of course, they would have distant metastasis. Now, when we analyze the cases done at Tata Hospital, and this is unpublished data, you would see that 37% of our cases were locally advanced. And you would now, in your practice, see this less and less more common, as you're going to see smaller tumors. But nonetheless, if you encounter a very advanced, locally advanced thyroid, more likely that it would be just a strap muscle invasion. The trachea, esophagus, and larynx are seldom involved, and they are less than 10% of cases. Now, when you look at an invasive thyroid cancer, and amongst the differentiated, less than 15% of them would be involved, and most of them would be papillary CA thyroids. Amongst the medullary thyroid cancers, you would have almost 40% of them with an extra thyroid spread, and most of them would be lymph nodal spreads, which are advanced. In anaplastic cancers, 70% of them would already have involved the organs in the vicinity. Patients above 50, tumors more than 4 centimeters, you would want to imagine that they would have an invasive component. And of course, when you clinically evaluate them, if they are fixed to the surrounding structures, you know that you're in for a surprise intraoperative. Of course, symptoms will also guide you towards the possibility of having an invasion. All these patients will have a poor prognosis, and also you would have possibility of complications because you are dealing with an advanced disease. And of course, they are morbid because then you will not be able to locate the important structures during your thyroid surgery. A case in point, a 57-year-old with a voice change in 3 years, having blood in sputum since last 15 days. A hard mass felt 2 centimeters on the left paramedian. When I actually see, it's not really looking as the first case that I showed you. The ultrasound showed a left lobe 6 centimeters into 4 centimeters, papillary CA thyroid, and the flexible laryngoscopy shows a fixed cord. So when you evaluate these with the imaging, you'll find that this is looking far more than what the ultrasound showed. There is a possibility that you have got a TO groove involvement, you have a possibility of a tracheal involvement, and you possibly have an esophageal involvement. So you will now want to investigate all this in order to preempt the possibility that you will encounter these intraoperatively. So remember, rarely does the invasive thyroid involve only one side. So you should have a complete investigation so that you do not miss anything. You might wonder why you want to do a laryngoscopy. 30% of patients with a unilateral vocal cord paralysis will have a normal voice. So just do not go by a normal voice. Preoperative vocal cord paralysis will indicate that you would have an invasive front of the disease. Also, a corollary is that an invaded nerve might still have function, and 45% of invaded recurrent laryngeal nerves present with normal laryngeal function. So just because you have a normal voice doesn't mean that you may not have a nerve involved. Everybody relies only on an ultrasound. And today, if you have symptoms, you should do a cross-sectional imaging, because ultrasound is dependent on the sonologist and may really not be able to evaluate all the structures that you want to see intraoperatively. The TO groove, the retropharynx, upper mediastinum are difficult to assess. So if you have a patient who's elderly, you have a fixed structure, you have symptoms which are not corroborating with an ultrasound, you should do a cross-section imaging. A CT scan is valuable and it tells you about the entire path of that disease and what structures are involved. And I would urge all of you all to read your own scans, because when you read your scan and you operate, it sort of fixes a roadmap in your head, and every surgery you learn more with the imaging. So sit with your radiologist, try and learn what are the structures that they are trying to point out to you, and in time I can challenge you that you will be able to tell the radiologist which structures are more likely to be involved. So in this patient, you could see that there was compression of the trachea, so the airway looked involved, and there is a clear intraluminal disease. So these are kind of things that you'll pick up, which we would have missed completely if you had not done a cross-section imaging. So remember, more than one structures are usually involved, and less than 25% will have only a recurrent laryngeal nerve involvement. So a recommendation to do a CT scan today is a large bulky primary tumor, bulky lymphadenopathy, and clinical evidence of invasion. Now when you see the CT scan, look out for the TO groove. Any effacement of the TO groove would suggest to you that you have a possibility that the nerve is at risk. So this is very important for us to do an preoperative counseling for the patient. Tracheal involvement is noted when there is a possibility of interluminal growth, luminal deformity, when there is a circumferential contact of more than 180 degrees, and if you have a mucosal thickening or irregularity seen. So if you have a lesion such as this, it's very obvious. But when you have a subtle compression of the trachea, you want to know whether there is an involvement. So you should do a flexible laryngoscopy, because it will tell you about the upper extent, the lower extent, the possibility of a mucosal lesion, which you might completely miss on something which is subtle. An obvious mass, you know that there's an interluminal disease. Now, in a situation like this, should you actually do a esophagoscopy? There is no interluminal bulge, a patient having a normal swallow. Why should you do a esophagoscopy? You should do because it is very difficult to visualize the esophageal wall on a CT scan because of lack of air in the lumen, and it's difficult to separate it from the adjacent soft tissue. MRI is less reliable, and ultrasound and CT have a modest ability to predict the esophageal invasion. So an endoluminal ultrasound, which uses high resolution probes, allows distinct visualization of the layers of the wall and can visualize the dimensions of invasion. And this will actually help you to plan your surgery and know whether you would want to do any reconstruction of the esophagus. So when you look at the studies done comparing CT, MRI and the endoscopic ultrasound, the specificity and sensitivity is highest with the endoluminal ultrasound. So if you ever have a lesion which looks intraluminal in the trachea or has a compression in the TO groove, you should do an endoluminal ultrasound so that you can evaluate the esophagus, not for an intraluminal disease, but to know whether there is an involvement of the muscles. So appropriate workup is important to prevent complications. It also has a prognostic significance, and you can plan your surgery. You can plan out how many more components of your multidisciplinary team are required for that surgery. Surgery still remains the best treatment for any advanced thyroid cancer. Recurrent nerve, I'm sure you all had discussed yesterday, and the whole uh, point of discussion is usually should you actually preserve or sacrifice the nerve, and what is the outcome expected in terms of function and oncologic safety. So, intraoperative decision for an invasive thyroid uh, involving the nerve is usually whether you can predict whether the nerve will be functional after resection, and usually intraoperative monitoring might help you towards that. Now, an intact nerve does not guarantee function, and an absence of signal does not imply damage. So, we know that intraoperative nerve monitoring hasn't shown to be beneficial, but as we are using it more and more in our practice, we know that we can rely on what's going to be the outcomes depending on the amplitude drop, etc. So, please try and use these adjuncts to surgery, because when you're dealing with an invasive thyroid, it might happen that both the nerves are involved. And then to make that decision as to which one you want to sacrifice or which one you want to dissect might be useful with the intraoperative nerve monitoring. Now, often you're wondering whether you want to shave the disease off or resect the nerve. So we know that there is data that comes in as way back in 95, where 24 nerves which were studied, 5 with fixed vocal cords and 19 with mobile. The ones with fixed, all were sacrificed, 80% survived. The ones with mobile vocal cords, 12 were sacrificed and 7 preserved, but there was no difference in survival. So we know that survival might not be the endpoints that we are looking for. What is the function of the nerves after dissection? So in this retrospective study of 50 cases, 23 nerves were preserved and 27 nerves resected. 80% of the preserved nerves had normal postoperative function. So what this brings into focus is that you need to use magnification in order to dissect out the disease, because many times you might get a good plane and you might be able to preserve a lot of fibers which will preserve function. And of course, it has no bearing or impact on the overall survival. So if your recurrent nerve is encased by tumor and preoperatively it is paralyzed, it makes sense to resect the nerve. If both the cords are mobile, you should spare the nerve, so go in for a proper resection. And if there's a contralateral paretic or paralyzed nerve, please spare the nerve because it will prevent a tracheostomy. Should you reconstruct the nerve, and what is the preference? Most post-operative studies have shown poor vocal cord function because of so many factors that we know about the adductor and abductor fibers and how that impacts the function of the cricoethnoid unit. So we know today that the best form of reconstruction is an ansa hypoglossite. The various other nerves have been used, but the ansa hypoglossite is the one that actually gives you a best reconstruction. This data from Mioci's group shows that when their nerve was involved in 88 patients, they did either a direct anastomosis or a free nerve graft or an anastomosis with the ansa cervicalis. And what happens is that the bulk of the muscle is preserved, so the maximum phonation time at 1 year is better in the patients with a reconstructed nerve. So recurrent nerve reconstruction achieves recovery in phonatory function in some of them. So as far as possible, if feasible, please do immediate re-innovation, because this is what's going to benefit the patient. Now coming to the visceral structures, again in trachea, you will have a disease which is coming onto the trachea. So often we are wondering, should you do a shave resection or a complete resection? Now shave seems a very feasible thing to do because nobody wants to open the airway. But we need to understand that there are issues with doing a tracheal shave. Negative margin intraoperatively is very difficult to determine. And also there is continuity between the peritracheal fascia and the dense fibrous tissue between the tracheal rings. So technically you might feel that you have removed the tumor, but you might leave behind microscopic disease. And tumor can spread into the tracheal lumen via the lymphatics within the intercartilaginous spaces. So this you have to keep in mind. If you are able to remove it completely and you have a bare cartilage, it doesn't mean that you haven't left behind disease. So a disease extension beyond the tracheal adventitia is known. You will have a possibility of local recurrence if you do a tracheal shave. Local control rates are as high as 95% if it does not penetrate beyond the perichondrium. But this is very difficult to know intraoperatively. This you'll only know later once you have studied the perichondrium and whether it was involved. So in most invasive thyroid cancers, you would have to rely on something other than radioiodine because now these are not going to take up radioiodine. So you have to make that decision intraoperatively. Is the shave a best for the patient because you might leave behind disease which you'll not be able to control with radioiodine. Now, when you have an intraluminal disease, our decision making is how much of the trachea to resect and how do you reconstruct. Now, we know that there is no possibility of a primary closure and it holding on. Primary closure of these defects are rarely possible. Only in cases where you might have just one ring which is involved and you can approximate it like a wedge. Most of the times you will have to reconstruct. So if you have less than 1/3 of circumference, you have resected one or two rings, you will still have to patch it with something in order to reconstruct the airway. But remember, this is highly morbid and fraught with problems because the moment the patient has a cough, whatever you are reconstructed with has a possibility of giving up. So try as far as possible, minimize this problem with a circumferential resection. Circumferential sleeve resection is the best form of reconstruction, and we know from Grillo's studies for the last 50 years that there is a certain amount of trachea that you can reconstruct primarily. It has very low morbidity. You can bring the approximate this with various maneuvers like the laryngeal drop, the intercartilaginous incisions, mobilizing the thoracic trachea, and finally even doing a Grillo's procedure where you divide the left from the carina and join it to the right trachea, right bronchus. But that's not what you would routinely have to do. Most of the times, 3 to 4 rings are involved, and you can do an adequate primary approximation by doing a laryngeal drop. But what is most important is to have understanding of the laryngeal function. Having done a restoration of the airway and having a poor laryngeal function will put this patient at risk of aspiration. So only and only if you are determined that you have one intact recurrent laryngeal nerve, both the cricoethnoid units are in place, only then you would do a end-to-end anastomosis. So prognostically, if the trachea is involved, incomplete resection is associated with increased mortality. And that we know because you cannot treat it further with radioiodine and you might have to resort to radiation, etc. So when they analyzed from the Grillo's group, segmental tracheal resection in 82 patients, the ones that had a complete resection, there was a 40% 10-year survival. And the ones that had an incomplete resection, less than 10% survival. So we know that whatever you do, try to reduce the morbidity and improve the oncologic outcomes by doing a complete resection. Now coming to esophageal invasion. I mentioned that you should do a EUS because you will know now whether there's a muscularis involvement or is it through and through into the mucosa. 95% of times you will not have to enter the lumen and you will never expose the mucosa. So you have a situation where you have the disease on the TO groove stuck to the esophagus and now you are wondering how to clear it. So you need to take precautions because whatever you do will have an impact on the outcomes because the lumen is going to be exposed. So usually it is confined to the muscularis, and if I have an EUS which mentions that only the muscularis seems to be involved, I can do only a muscularis resection and preserve the mucosa and submucosa. This is how you would resect it, and you would then clear that entire muscle off, exposing the mucosa. Now you're left in a dilemma. Do I need to patch this, or is going to, have a deep, the vascular supply is compromised and it's going to blow post-op. So we have had occasions where we have been gung-ho about this and we left it, and the patient's having a cough, third day, fourth day, and he's having saliva into the neck drains. So wherever you have removed the muscle, you need to prevent this complication by putting a muscle patch over it, even though the mucosa is intact. So if I leave you with an algorithm, if there's a full thickness involvement, of course you have to do a composite resection. Small defects, you do a primary tension-free multi-layer closure like you do for a pharynx. If it's extensive, you need to reconstruct with a myofascial or a myocutaneous pedicle flap. So you can do a primary repair, and please use adjuncts like tissue glue because this will hold those tissues in better. Use a vascularized flap, especially in cases where there is a irradiating neck. So restricted to muscularis, excision of the muscularis of the affected segment is sufficient. If there's a luminal mucosal involvement, do a partial esophagectomy and reconstruction. Coming to the larynx, you would often find that the tumor creeps up along the cricoid coming onto the thyroid cartilage, and on the scan it looks as though the larynx is involved. Many times it goes into the piriform and in the paraglottic space without having destroyed the cartilage. In those cases, you can easily get a subpericondylar resection and clear it. At times, the cartilage is involved. Now you're wondering, should I actually do a partial laryngectomy or a total laryngectomy? Now, this brings into focus the same issue that we had in tracheal reconstruction. If my laryngeal function is preserved, if my arytenoids are intact, if I have one recurrent nerve, I can still do a partial laryngectomy. Remember, for a lesion which is involving the paraglottis, which was squamous cell, we would do a partial laryngectomy. If I have an intact cricoid, I can do that and resect this cartilage without having to enter the larynx. So most of the times, we will be able to clear it off with a subpericondylar resection. But if the cartilage is involved, you would want to do a partial laryngectomy only and only if you have an intact cricoid. So you can see that the cricoid is intact here and only this part of the cartilage was destroyed. So you can do a resection and preserve the paraglottic space and you are not entered into the larynx. So shave procedures should be done only in cases where you can actually clear this lesion, and partial laryngectomy done for patients with lateralized intralaryngeal disease. Very rarely you might have to go in for a total laryngectomy, but it is an appropriate surgery because this patient is not going to have any other possibility of local control other than surgery followed by radiation. Finally, coming to vascular involvements, you might have cases where you have got large tumors which are coming onto the vessel and involving the internal jugular vein. Now, surprisingly, with papillary thyroid cancers, very rarely are the veins involved, but they seem to be more adherent to the carotid. So you need to be more aware that the vein might come off, but the carotid seems to be something which you cannot clear. So you need to investigate, and like we are talking all through, if we have better planned, we can actually do a good surgery. This may be the only indication in head and neck where you might do a resection of the carotid and the patient is going to benefit from that surgery. In head and neck squamous cell cancers, we know for sure that carotid resections are of no use. So for lesions such as this, you would want to investigate with imaging. You might even do DSA in order to know whether there's an interluminal involvement. and you need to plan for reconstruction, adequate reconstruction. So if your carotid is involved, you need to keep a vascular standby so that you can reconstruct that carotid well. CE, CT and MRI are good sensitivity for investigations, and you should consider doing a proper evaluation. Many times we might have to excise an internal jugular vein, and you need to prevent a complication of having bilateral jugular resections, because these need to be avoided. This is one surgery wherein you can go back in and do it again after 6 weeks to 6 months, because this patient is not going to have as poor survival as a squamous cell cancer. But certainly, if you want to do an internal jugular vein resection bilaterally, today with vascular reconstruction methods, you can reconstruct it, and you should. So, for carotid resection, you need to assess the patency of circle of Willis before, and then have a vascular surgeon as a standby. So, in summary, we are trying to avoid complications in thyroid invasive cancers, and the goal should be to have a multidisciplinary team investigating this patient and managing it. You cannot have an intraoperative surprise, and it can be avoided if you investigate carefully. So, understand the tumor biology, understand the extent of local invasion and nodal disease. You need to check for distant disease before planning out any reconstruction and surgery for a locally advanced disease. It just may not be worth it if the patient has a full-blown metastasis all over. You need to plan out what's going to be the adjuvant therapy, because if you're going to plan out radiation, you should have a vascular flap in place so that the patient can withstand that. And of course, you need to plan out what's going to be your surgical morbidity so that you can explain to the patient. Thank you very much.
For your excellent informative talk. Open for question and answer session.
Dr. Prathamesh, good talk. I just wanted to know if you could elaborate on how will you investigate and manage a thoracic duct injury?
So the thoracic duct injury is common in medullary thyroid cancers with large nodal metastasis, and we have seen it because we are doing a dissection. Most of your thyroid thoracic duct injuries are lateral to the carotid and encountered with large nodes in the level 3 and 4 and 5. Now, in a medullary CA thyroid, you would have tracheoesophageal groove nodes which are also enlarged, or you're dissecting the mediastinum. So that part of the thoracic duct that crosses across from the thorax onto the neck behind the carotid is what's getting injured. So in those patients, you would have no option but to do an interthoracic ligation. So for a neck node which is lateral in level 4 and 5 dissection, you know that it suffices to take a control on the thoracic duct, and you can actually do a good compression of that thoracic duct. I'm using the word compression because you can't suture it. So you have to compress it between some structures, some tissues. Anything medial to the carotid, you please go ahead and do an interthoracic ligation. Today, there are intervention techniques where they use embolization of the chyle duct. I've had opportunity of only 2 cases where they've been successfully done. You can avoid an interthoracic surgery. But the interthoracic endoscopic surgery is so less morbid today. They just have to open and put 3 clips on the thoracic duct and that chyle stops. It just takes them 15 minutes.
Dr. Prathamesh, excellent presentation and excellent cases. Of course, every surgeon will face this sort of problems, one or the other.
Luckily, less.
Period. No, in fact, yesterday I spoke a similar type of presentation of difficult thyroid tumors and their surgical management. I showed some of the scenarios.
Right.
Of course, in those cases, in one of the case, very advanced CA involving the larynx crossing to the opposite side. I gave option of total thyroidectomy with preservation of larynx. I could not do. On the table, tumor was infiltrating to the larynx. Then I went out and discussed with them. Of course, I gave an option even preoperatively. I did a total thyroidectomy and laryngectomy. While doing laryngectomy, in fact, I had a fear whether esophagus is normal or not. Suppose esophagus is not normal, even laryngectomy is not going to be beneficial. So here what I felt, the muscular layer as you said, is the mid part of the esophagus, midline. It is not the side. It was a little bit indurated. But in spite of that, I shaved the muscles, I removed the muscular layer, and I did a laryngectomy as usual. But patient survived for 10 to 12 years. Again, he developed recurrence in the same esophagus, and of course, he was not willing for a pull-up. Probably, I would have done a pull-up in the beginning itself. He would have survived for a
Did
long
you
time.
radiate him, sir?
Pardon?
Did you have radiation as an option?
Yes,
after
yes,
surgery?
they have given twice ablation, twice,
No, not
sorry,
radio ID, external beam
post-op
radiation.
radiotherapy was given, already given, but still there was no response at all.
So my first slide, I showed that we may have to differentiate and understand the biology of this disease. Are we dealing with a poorly differentiated thyroid and anaplastic thyroid? Because you will have complications in those patients. Now, I had a case which was a poorly differentiated thyroid, and finally, final pathology showed it was an anaplastic. There was some small hemorrhagic tissue on the esophagus. We just took it off the muscle without paying much attention. We knew it was invasive thyroid, reported as a well differentiated thyroid. We operated. After 3 days, to our horror, the patient had a complete esophageal dehiscence. It was an anaplastic thyroid. It had gone all along the esophagus, right from the neck into the thorax. It had opened up. Now, these are the kind of problems we'll face if we are not sure of what the biology is. So today, in hindsight, maybe I would have done a true cut, because I know that this is not, it's a fixed kind of a tissue. It's not moving much. Maybe I've done a true cut and got a better image, got better understanding of the disease. So these are situations. Today, 95% of our cases are going to be small, not 1 or 2 centimeter nodules. The ones that you get which are large, the ones that you get which are fixed in elderly population, you should investigate with a biopsy, because you will get some more understanding and we will avoid complications intra-op and post-op.
Excellent talk, very educative, fantastic cases. So one question: in today's time, would you still operate on these cases, or would you like to give TKIs as a new adjuvant therapy, and downstage them so that your surgery
we want
becomes
to know
easy?
more, like you said, so that we want to know whether these are poorly differentiated or undifferentiated or anaplastic. And if they are one of these variants, you would want to do a next generation sequencing. You want to know whether they are responding and all these, because the patient is not going to die in front of you.
So no, my
You would
question is
invest.
slightly different. Suppose it was not poorly differentiated, not anaplastic, but an aggressive DTC, aggressive by the behavior. It's DTC.
Yeah.
So it's, rather than operating, it's even in those cases, perhaps a course of TKIs would make your job easier.
Of course, there are a lot of good reports which have suggested that there is a good response and that you might want to consider doing these TKIs upfront, but not much of any clinical experience.
And the other, I can share a trick for the thoracic duct injuries. Use Trenexa a lot, It really helps in your chyle leaks.
Tranexamic acid.
Yes,
Locally.
chyle leaks close on their own.
Locally.
Injectable
No,
or local?
just injectable and then oral.
Oh, okay.
I have seen chyle leaks which are 500, 800 output. In 3 days, it stops.
I see.
It's a fantastic drug for chyle leaks.
What is that?
I don't know, it really constricts the blood vessels, it's known, but it has an effect on the duct also.
We use
give-
opioid.
we give opioid. Opioid is very
Opioid actually doesn't work so well, but try this Trenexa, it really works very well.
Opioid has very good results. It has to be given
That's also
BD.
50%, no octreotide. Is it very good?
So Abhishek, only thing, my take on octreotide is, if you have a high output leak, please explore.
Explore, of course.
If you have a small quantity of leak which is coming in, because that your length of stay is almost doubled.
So this is not an escape route for not exploring when you have a very evident leak, very large volume leak on day one.
Exploration is very difficult in the sense that tissues are very fragile. So I have seen how output leak. I used Trenexa and it stopped completely.
We'll try it. We'll try
You
it.
must have.
Yeah. So regarding, I spoke about this yesterday. Lenvatinib, the good thing is it is NGS agnostic. It doesn't depend upon what kind of molecular, um, um,
It's
marker is there.
it's not
And
specific.
therefore, you can
Not
use it
specific.
in differentiated thyroid cancers. So anywhere where you are anticipating an R2 interface or an R1 interface, you can use lenvatinib. And it
only
has
case
excellent safety data from RCC.
Only case that I had seen being used was where there was a large node at the aortopulmonary window, and they gave TKI, and it just seems to have melted.
So I've done this for 6 cases now.
Yeah.
So
All DTCs.
DTCs, no, some solid variant, some insular variant,
Yeah,
but
not
but all follicular derived
That's
cancers.
the message. Not
All
only
for-
for PDTC
Yeah, yeah.
and anaplastic, but even for
Yeah,
aggressive DTC.
absolutely, absolutely.
Rather than going
They are
in and
agnostic
facing
to
these kind of
molecular
situations,
changes. Yes.
you can downstage with the help
In
of
fact,
inverter. But you
there's-
have to find that correct window when you can operate.
Yeah, there is a trial approving right now with Dr.
Yes.
Randolph. So one thing I wanted to ask, technical question. Suppose there is disease on the posterior, the disease has gone into the T groove posterior to the trachea. Now it is involving the membranous trachea. Now that is very, very difficult to resect and reconstruct. Even if you do segmental, you'll never know how much.
So that's the case in point. If you're seeing a tracheal involvement, you should investigate the esophagus. And of course, if you had the possibility that the parting wall between the trachea and the esophagus is involved, you would have to take a call whether you want to do a resection. Now, for the trachea, you're going to do an end-to-end anastomosis. You're going to resect it, right?
Yeah.
So-
Either put in a patch, do laryngectomy, put in a patch for the
Why would you
esophagus.
do a laryngectomy?
No, because you large tracheal resection.
Suppose the same thing, the level from the second ring to the fourth ring, it's involved, but it's going posterior.
Yeah.
It's going in the TO groove. I mean the tracheoesophageal parting wall. Now you would want to circumferentially clear it, like you do for any gastric problem. You circumferentially resect it, and you find that it is now stuck to the esophagus. You would then have to take a call whether it is now involving the muscle at that point or the esophagus or the mucosa. If it mucosa is also involved, you know that you have to reconstruct the trachea and you're going to reconstruct the esophagus. At that point, you want to know whether both the nerves are intact. If both your nerves are intact and you still have to do it, then I think that should be done. But I've not
It's a
encountered this.
difficult scenario. You witnessed a case I was doing in light surgery. This happened, so we had to put in muscle there. She leaked for a while.
So, just a question and your experience about in a locally advanced differentiated thyroid cancer, when you will do a laryngectomy for the patient, because we had a discussion yesterday also and we were talking, I think your point of view on that, and when you have a unilateral disease which is locally advanced in a differentiated, how you handle safeguarding other side recurrent laryngeal nerve, or your take on recurrent laryngeal nerve, how you handle it in a locally advanced cancer?
So, in any thyroid, if it's an enlarged thyroid, I will go for the easier side first. I will preserve that nerve. I'll, now with intraoperative nerve monitoring, check and see that the nerve is preserved. So, and then going for the involved side. Now, for the larynx, if it is involved, I would want to determine where is it involved. Now, if the anterior part of the cricoid is involved, you know that you can resect it and you can put in a partial cartilage and reconstruct it. If the posterior part of the cricoid is involved, you will not be able to reconstruct because both your cricoidnoid joints are at risk. So my take on doing a laryngectomy where the posterior part of the cricoid is involved, it is the entire length of the cricoid cartilage where I cannot do a partial resection, and I don't have both the recurrent nerves, free. So I'll be pushed to do a laryngectomy if I have a situation like that.
Any role of using free flap or anything, any advances or anything, just because it's a thyroid,
So
not,
for a
not
larynx,
squamous.
the most important thing is your cricoid. So that's the rostrum of your larynx, airway. So if my airway is compromised, I will not be able to keep it intact. I'll end up with a tracheostomy at some point in time. So your free flap and all will not be able to reconstruct this. So if you do a near total laryngectomy and you're able to save part of the process, the shunt, then that's what you can offer that patient. But I don't think if the cricoid is involved, you will be able, posterior cricoid is involved, you'll be able to save or avoid a laryngectomy.
So how often you have done a laryngectomy for a differentiated?
Very
how you
rarely.
choose, like,
Very
patient
rarely.
convincing,
Like I said, you would
consenting?
have the way the disease spreads is lateral spread. It's never posterior or it's very rarely anterior. So it's the one which is an isthmic part which is then gone into the cricoid. That's where you have the anterior involvement. Most of the times it's lateral, and it is just at the junction of the cricoid and the first ring. So when you are resecting it, you might resect part of that cricoid and maybe take off that first ring, and then that's adequate because the rest of the cricoid is intact. So you will then do a cricotracheal reconstruction.
Thank you very much. Thank you very much. Very nice points.
Prathamesh, one more question I just want to ask. In a tracheal infiltration, if you are planning for a resection anastomosis, you say you want both vocal cords should be mobile. Recurrent laryngeal arytenoid should
So
be
one vocal cord.
Okay, both are, if they're mobile, you are safer, much more safer.
Yes.
If one is mobile, another is fixed, the safety is not 100%.
Sure.
Depends upon, because one aspiration, there is a risk of aspiration will be there in those cases. Suppose if there are both vocal cords are fixed, do you is it possible to do a resection anastomosis?
I wouldn't do it, sir. I would just leave a large tracheostoma and then, look out for the function post-op. Now with intraoperative nerve monitoring, that element is also taken care of. You will know for sure whether there is a transmitting impulse or not. If the nerve is non-functional, you would want to do laryngectomy.
Last question, Prathamesh. If I have to do a partial resection of the esophagus wall circumference, then how do I reconstruct which is the best modality and which is how to look at the viability of the flap?
So we have had occasion to do it only twice, and both of the times we use a free flap to reconstruct.
And how to assess the viability of that flap?
So the ones that one case they left a monitoring paddle outside, so that they could monitor that. This is like when we do a gastric pull-up, we get one monitoring paddle out. So that is incorporated in the suture line. So that's very easy to do, a free flap.
Thank you.